Welcome to The Code Trade, a podcast of the ACCP Emergency Medicine PRN. I'm your host, Christian Kroll, an emergency medicine ICU pharmacist at the Mayo Clinic. To view this recorded presentation, head to our YouTube channel at youtube.com/@ACCP EM PRN. And for PRN members, slides can be found under the Libraries Entries section of the ACCP Communities website.
Our next presenter is Sharon, a PGY2 EM resident at Scripps Mercy San Diego, who will be presenting on the journal article Adjunctive Terlipressin versus Placebo in the Treatment of Refractory Septic Shock, a randomized placebo-controlled trial.
So to go over what I'll be presenting today, I'm going to review the guideline recommendations for vasoactive management in septic shock. I'll also review the mechanism of action of terlipressin and its potential use in refractory septic shock, and identify potential populations, benefits, safety considerations, and limitations of terlipressin. So going into the background, the sepsis is defined as organ dysfunction caused by a dysregulated host response to infection. So there's an upregulation of pro and anti-inflammation, leading to an increased release of cytokines and inflammation, leading to vasodilation and capillary permeability, thus leading to hypotension and distributive shock. This is from the 2021 Surviving Sepsis campaign. The guidelines recommend targeting a MAP greater than or equal to 65, using norepinephrine as the first-line vasopressor, and it is recommended to consider adding vasopressin when norepinephrine reaches low to moderate rates. And of course, if hypoperfusion persists, the guidelines recommend adding dobutamine or switching to epinephrine. The guidelines actually do have a weak recommendation against the use of terlipressin in the setting of sepsis shock with moderate quality of evidence. But just to review what terlipressin is, it is a synthetic vasopressin analog that acts as a prodrug to lysine vasopressin, and it also has activity on its own. This leads to a slow release effect with a longer half-life. It acts on both V1 and V2 receptors, leading to vasoconstriction and free water absorption. Terlipressin does have a higher selectivity for V1 versus V2, and these two actions lead to an increase of mean arterial pressure. And of course, we know that this is a different mechanism of action compared to norepinephrine, which acts on alpha and beta receptors, all in all leading to a multimodal approach to help increase mean arterial pressure. Going into some background studies that measured terlipressin in septic shock, there's two previous trials that measured monotherapy terlipressin compared to standard of therapy. So in 2018, Liu and colleagues compared terlipressin directly to norepinephrine, with the primary outcome being difference in mortality. They found that there was no difference in mortality. However, there was a higher rate of digital ischemia in the terlipressin group. And overall, there was more serious adverse events in the terlipressin group compared to norepinephrine. So they had concluded that while terlipressin is not superior to norepinephrine, it may increase adverse events. And Huang in 2020 compared terlipressin to catecholamines such as norepinephrine, epinephrine, dopamine, and dobutamine. And what they had found was that there was no difference in mortality rates in the total sample size. However, when doing a sub-analysis, they found that there were lower mortality rates in the terlipressin group in younger patients. Terlipressin did have a higher decrease in creatinine levels. However, terlipressin did have a higher rate of peripheral ischemia, similar to the previous trial. And so the authors concluded that while it may not reduce mortality, it may reduce catecholamine exposure. Just to review the adverse events that occurred in the 2018 trials, so they assessed acute myocardial infarction, life-threatening arrhythmias, acute mesenteric ischemia, hyponatremia, and diarrhea. However, there was no difference in these severe adverse events, suggesting that the digital ischemia was the driving factor for the overall more adverse events in the terlipressin group. So these studies support that as monotherapy, terlipressin does not provide any further benefit in survival outcomes, again, supporting the Survive Sepsis campaign. But it does beg the question, how would adjunctive terlipressin affect patient outcomes versus monotherapy? This goes into the trial that I'll be presenting today. It's adjunctive terlipressin versus placebo in the setting of refractory septic shock. It's a very well-designed study. It's a prospective, single-center, double-blind, randomized controlled trial in Thailand from 2020 to 2024. The inclusion criteria was adults in the ICU with septic shock requiring vaso support despite fluid resuscitation, and they had to have an elevated lactate. For exclusion criteria, they were excluded if they had prolonged septic shock, if they had a DNR plan, if they had severe chronic or liver disease, and if they had concomitant cardiogenic shock. So the trial used the definition of sepsis similar to the Surviving Sepsis campaign, which is life-threatening organ dysfunction. They used that by using the SOFA score, which assessed dysfunction in respiratory, coagulation, liver, cardiovascular, central nervous system, and renal function. For the definition of sepsis shock, so patients were to have, of course, the inclusion criteria, and then they also had to be on either norepinephrine of a rate greater than 0.2 mics per kilo per minute, or if they were already on norepinephrine and epinephrine. So in terms of the study design, once the patient met inclusion criteria by having fluid resuscitation, starting catecholamine vasopressor, and were admitted to the ICU, they were randomized into the placebo or the terlipressin arm. As the patient is improving in terms of their health, providers can start tapering the catecholamines down. And then once the catecholamines were tapered down, they can start tapering down the placebo or the terlipressin until it's turned off. For primary outcomes, the investigators studied the successful septic shock hemodynamic stabilization within 6 hours. And so the investigators defined this as having a MAP greater than or equal to 65 with a total catecholamine requirement less than 0.2 mics per kilo per minute. And then total catecholamine requirement was calculated by adding the norepinephrine dose to the epinephrine dose and the dopamine and dobutamine dose. For secondary outcomes, they measured 28-day ICU and hospital mortality, mechanical ventilation requirements, and adverse events. For their statistical analysis, they detected a 25% difference in successful septic shock stabilization as long as they had 114 patients, which would allow an 80% power. And then to account for a 15% dropout rate, 130 patients would be required. And so the investigators did reach power. 315 patients were evaluated, 185 were excluded, leading to that 130 patients reached. However, they had 64 in the placebo group and 66 in the terlipressin group. For baseline characteristics, you can see that the baseline characteristics were evenly distributed among the two groups. Something that I thought was interesting was that the age had a median of 65, 64, and majority were male, which I think reflects our ICU population pretty accurately. Something else that I wanted to note here was that their SOFA score were pretty elevated at 14-13, suggesting a pretty high acuity patient population with very elevated serum lactates. For underlying diseases, again, very evenly distributed amongst the two groups. However, it did seem that there was numerically a higher number of diabetes patients in the terlipressin group compared to the placebo group, but not significant nonetheless. I also appreciated that the most common underlying diseases were hypertension, diabetes, and chronic kidney disease, which I think, again, reflects our patient population pretty accurately. For site of infection, a majority of the population had a respiratory tract infection, followed by intra-abdominal infection. And then I feel like, again, in terms of sepsis, I think respiratory tract is a pretty common cause for sepsis shock, one of the most common causes of infections here in the hospital. In terms of their catecholamine use, so of course, norepinephrine, it was 100% in both groups, as that's a requirement. And then following the norepinephrine is epinephrine, and then dobutamine and dopamine. So going into the results, the primary outcome of reaching successful hemodynamic stabilization within 6 hours, they found that there was a significant difference. There was a higher number of patients that reached the primary outcome in the terlipressin group compared to the placebo group. And you can see that the relative risk, the 95% confidence interval does not cross 1. For secondary outcomes, there was no significant difference in mortality rates either in the 28 days, ICU, or hospital. And then as for number of patients that required mechanical ventilation, there was also no significant difference. And then just to provide a visual of the 95% confidence intervals and the relative risks for the secondary outcomes. And then for mechanical ventilation. And then for adverse events, so they had measured arrhythmias such as AFib, SVTs, VFib, and VTAC, digital ischemia, digital gangrene, bowel ischemia, and recurrent shock. And as you can see, there was no significant difference among the adverse events. However, if we look at bowel ischemia, you might notice that the confidence interval actually does not cross 1. However, the p-value is not significant, so although the 95% confidence interval may suggest otherwise, it's not statistically significant. And then again, just to visualize the outcomes in terms of adverse events. So for limitations of this trial, median time from septic shock diagnosis to Terlipressin initiation was 14 hours. And then the study was only powered to detect a difference in hemodynamic stability and not mortality or other adverse event complications. So the authors' conclusions of this trial suggested that adjunctive terlipressin does improve early hemodynamic stabilization in refractory septic shock, but does not improve mortality or adverse events. Another note is that although there were no significant difference in adverse events, the study was underpowered to detect a difference, so that this could have a higher risk of a false negative. My considerations for this trial, comparing terlipressin to current therapy of vasopressin, it's much more expensive. And when we think about what an ideal drip or an ideal vasopressor is, we tend to look at the onset, half-life, and duration. And so for vasopressin, it does have an immediate onset, a very short half-life, and it does have a very fast offset, making it an ideal vasopressin to titrate as a drip, going up and down in terms of rates. And then for terlipressin, it does have a delayed onset because of its metabolism. It does have a longer half-life, and it does take hours to offset after stopping the infusion. And therefore, it may not be as an ideal vasopressor when we're considering management in terms of titrating up and down according to the patient's needs. And it's much more expensive, as you can see. So in terms of future considerations, future studies should compare terlipressin to other adjunctive vasopressors, such as like vasopressin, epinephrine, dobutamine. Optimal dosing, infusion rate, and duration of terlipressin for septic shock also remains unclear. And then the generalizability of the study, it was done in Asia. And so in terms of the Western hemisphere of the world, it may not be as applicable where we may have higher comorbidities and more higher acute patients. And then I will start accepting questions.
If you have enjoyed this presentation content and would like to hear more, subscribe via your favorite podcasting app. Additionally, make sure to check out our YouTube page for all recorded presentations. Thank you for listening to this week's ACCP Emergency Medicine Journal Club presentation. Join us weekly for review and discussion of new journal articles in emergency medicine. This podcast provides general information only and does not offer individualized medical or professional healthcare services, including pharmaceutical advice. The contents and materials in the podcast are not intended to be a substitute for inpatient pharmaceutical advice, diagnosis, or treatment. And the use of the contents and materials in the podcast does not constitute a pharmacist-patient relationship. As a result, the information in and materials linked to this podcast are applied at the user or patient's own risk. Users or patients should consult their physician or personal healthcare professional. The user or patient should not ignore or delay seeking care because of something they heard on this podcast. In case of an emergency, the user or patient should contact their physician, call 911, or go to the nearest medical emergency facility. The views and statements expressed on this podcast are those of the host and guest and should not be interpreted to reflect the official position or policy of ACCP or the Emergency Medicine PRN.